everyone. This time we're going to do what we're going to call upper GI, a miscellany, which means like just kind of the stuff that didn't really feel like it fell naturally into anything else. So, upper GI, things that we have to think about in an upper GI, really a question stem than anything else. But let's talk about the esophagus first. So the esophagus, let's real quick on the anatomy. You have the upper esophageal sphincter, which is at the pharynx. I'm not really sure on this diagram what the subsite descriptions were supposed to be, but so you can see though, the pharynx goes into the esophagus, and then you have the lower esophageal sphincter at the stomach. And then in between, you have the anatomic constriction. So the cricopharyngeus muscle at C6, the aortic arch at T4, and the gastroesophageal junction T10 to 11. So right where it goes through the diaphragm kind of their area there. So and then also the pediatric patient has the thoracic inlet at T1, the tracheal bifurcation at T6. Why does this matter? Because these are the places that foreign bodies can get stuck. So words that we have to be familiar with: dysphagia versus odynophagia. So dysphagia means you have a difficult time swallowing. You're maybe drooling. You could have that sensation of food in your neck, like that bolus sensation. This could be an obstructive dysphagia, right? You got something in the way you can't swallow. It could be a motility dysphagia. Your muscles aren't working in the correct order or in the correct sequence, and you're not able to achieve that peristalsis movement. If there's an obstruction, you might consider a CT, soft tissue of the neck. If it's a foreign body, you can get the X-ray, but unless, I mean, a lot of foreign bodies are not are translucent. You're not going to be able to see them anyway. If you're thinking like a toddler or something like that, you might get a foreign body series, which actually goes through the entire GI tract looking for, things like button batteries and magnets and stuff like that. If you have dysphagia, you are an aspiration risk. 30 degrees head of the bed, please. Odynophagia is pain with swallowing. And this, so you really have to make sure you're using the right word, right? Dysphagia is tough time swallowing. Odynophagia is that you're having pain with swallowing. This could be esophageal inflammation or erosion. And you know what? It's probably infectious. So I don't know if you remember the last time that you had like strep throat or something along those lines, some kind of even a viral pharyngitis. You can get odynophagia with that, right? You're not having a hard time swallowing. It's just that it's painful to swallow, and you may not be choosing to swallow because of the pain. Other things in the esophagus, there's GERD, which we also call heartburn. So the lower esophageal sphincter lets food in the esophagus. Maybe it's weak or there's some transient relaxation. This happens with like high fat food, people who eat high fat food, people with nicotine, ethanol, caffeine addictions. I kind of the stereotype, right, is that one uncle that everyone has who chain smokes, drinks too much, and chases it with coffee the next morning, and they're always walking around burping, maybe fistful of Tums kind of thing. So medicines can cause it, right? Calcium channel blockers can cause that smooth muscle relaxation in the esophagus. If you're taking a nitrate, hormones, those can all cause it. Pregnancy can cause it, as the oxytocin, or not oxytocin, the relaxin also relaxes the smooth muscles up there as well. So the big thing about GERD though is you got to be sure it's not an MI. You have it's kind of that substernal chest pain. People might call it burning. They might say that it's the same as their acid reflux. Um, GI cocktail, if that treats it, it doesn't mean it's not an MI. You still absolutely have to rule that out. I've had that patient where he was early 60s. He came in dead. He just tipped over at a family get together, and his heart had stopped. They started CPR. We never ever ever had a chance of getting him back. And I was talking to the family. I was like, "Hey, was he complaining of anything this week?" And they're like, "No, no, everything was fine this week. He was just complaining about his heartburn acting up." And then 5 days of that, and then he comes in dead. So give him Pepsid at home. Tell him to follow up, right? If you know it's actually heartburn, or if that's what you're actually gonna, your highest, right? Other bad things in the esophagus would be like esophageal perforation. The most common cause would be an iatrogenic perforation, so someone who just got scoped, or someone with lots and lots and lots of vomiting. You have to be vomiting pretty hard for this to happen, but it does happen, right? So again, you're thinking an alcoholic who had a binge drinking and is paying for it the next day. Borov's is a full thickness perforation, and the issue is that you can dump the contents into the mediastinum, so you get pain everywhere, including the back and shoulders, because you have all of that inflammation happening throughout the thoracic cavity, throughout that mediastinum. Um, and then that pain radiates to everything. So you can get some abdominal rigidity, fever, hypotension, tachycardia, tachypnea. If you have ever had the chance to feel that snap, crackle, pop that they talk about on palpation, you ever hear about anyone in the department having snap, crackle, pop, make sure you go push on them. You need to feel that for yourself to really understand. It is absolutely like Rice Krispies underneath the skin. It is crazy the first time you feel it. You might also be auscultating their heart. And since you're right over that mediastinum, sure enough, you're going to get some snack, crackle, pop, right? That makes sense. It's all in that same geographical area. So for these people, you got to resuscitate them. You got to, oxygen on the monitor, 2 large bore IVs. They can easily decompensate on you. Call surgery right away. Get the CT soft tissue of the neck and chest with contrast. Make sure you're able or they're stable to go down to the CAT scan because ain't nobody happy when you're running a code in CAT scan, right? Other specific pathologies for the esophagus is the foreign body ingestion, kids and kid like, right? So, not just kids, but also those with maybe they're mentally debilitated for whatever reason, whether it's a congenital issue or years of being sick, or maybe they have dementia in their old age. Those all can have foreign body ingestions. Um, Unless it's food, you're not going to be able to see it, right? Retrosternal pain, uh, so you can get plain films if it's radiopaque. If it's food, like a food impaction, it won't show up, right? So who needs a scope? You got to do some stratification. If it's not sharp and is past the pylorus, don't worry about it. If it's irregular, sharp, wide, or long, worry about it. First things first, assess the airway, ABCs, right? So you want to make sure they're tolerating secretions. So you're going to call GI for this to see if they need a scope. But you know what they're going to say is like, did you give glucagon? My experience of glucagon almost never works. According to our literature in the ER, glucagon pretty much never works. But they're going to ask you to do it. So just go ahead and pull the trigger on that first dose of glucagon and tell them that you tried. So give it 1 or 2 milligrams IV, repeat in 20 minutes. You're only going to do that. You're only going to repeat it one time, though, okay? But the idea is that it's going to, it works on that CAM pathway, kind of like why you would give it in a beta blocker toxicity. Other upper GI stuff, PUD, gastritis, pelvic ulcer disease, right? So kind of the same thing in a way. You're talking about you know that irritation, that inflammation of that area. So often this is from aspirin and NSAID use. It can be from too much acid, not enough mucosa, or not enough bicarb to neutralize all those things that can create an acidic environment and wear away that mucosal wall. So I mean, the main thing, it's really a structural issue, right? Like you've got your wall, and then you got your mucosal covering, and then you got all the acid that it's protecting it from. If there's any kind of compromise in sort of that system, you're going to get this peptic ulcer disease or gastritis. So the presentation is most likely going to be like epigastric pain that is cyclic. Some people call it burning, some call it gnawing, some call it aching. I feel like I hear burning most often. It could be tender to touch. Okay. Um, Not always, but the big thing is watch for changes in character. If they always have, if they've got a history of ulcers and they come in and say, "Hey, my ulcer pain," you got to be like, "Why are you here?" Then you know it's your ulcer. What's different? What's new? Is it the same pain, just worse? Is there a new feature to it? And then again, just based off of location, you still have to consider cardiac and pulmonary causes. So going back to that same example, that guy thought it was just his reflux acting up. It was a cardiac issue. So don't trust that if they say I've got ulcer disease and this feels like my previous ulcers, you still have to prove that it's ulcers. So for workup, again, history, right? NSAIDs, aspirin, smoking. Do they have a history of pelvic ulcer, pelvic peptic ulcer disease? What kind of abdominal pain are they having? Then it goes to I use OPQ, but whatever you use to characterize that pain. Any diarrhea, any weakness, you're gonna get labs, right? CBC, lipases, the pancreatitis. So that lipase is gonna help you assess for that. Electrolytes, again, the BU and creatinine. If it's bleeding, you're gonna get that 30-to-1 ratio, right? BU and creatinine. Check their glucose. And then consider, do I need to type and screen on this person? Is this someone who I think might actually be experiencing a bleed that I need to consider a transfusion either now or in the next several hours? Get a chest X-ray. You can get signs of pneumomediastinum, so air in that mediastinum. That'll give you an idea of perforation. 100% get the EKG. I get EKGs now on basically anyone with nausea and vomiting of any age, especially with epigastric, and then plus or minus troponin, depending on if your risk stratification. I know you can't actually do a hard score with the troponin, but if you calculate everything in the hard score except for the troponin, and then you can kind of see if that's gonna that one troponin will push you one way or the other. Other workup stuff. So departmental pain control, you can do antacids, IV H2 antagonists, so like a famotidine or whatever. You're gonna end up sending them home with and also consider decompressing with a nasogastric tube if you're concerned they might be obstructed. But you're gonna end up sending them home with a PPI or an H2 antagonist. You can send them home with sucraf, sucralfate. Why can't I say that? Sucralfate. Anyway, you're gonna send them home with that, right? And antacids. I'm a little cautious in antacids. I want to make sure that they have more than one option because antacids are a fair amount of calcium. I've actually had patients come in who are like super hypercalcemic, like calcium levels of 16, 17, and they were alcoholics who had a history of ulcers and they were just slamming antacids by the fistful every day, and they actually got themselves up to a calcium of I think it was 16 and a half. I mean, that's crazy. So, Protonics or famotidine, omeprazole, like whatever makes sense in your case, right? And then the things you're watching for: hemorrhage, perforation, or obstruction. What's next? Oh, that's it. That's not bad. That's a pretty short one. So just kind of wrapping up or trying to round out the abdominal pain stuff. Thank you very much for listening. Once again, this is Micah with the Art of Med School, and we will catch you soon.